So I won't detail the technique itself, because this will be done later. But what I will try to define is the background of this technique, because what happens is the deep pelvis is sometimes poorly known by all of us. And we'll try to move step by step from the anatomy, the mechanical functioning of this anatomy and dysfunctioning to explain the pathology that we will face, and then explain what are the key points on which the solution is leaning. The solution is quite simple, but the background is complex. And of course, if you make an inquiry, you may define that almost one woman out of two at the time of her age is suffering some kind of problems like this. And after some inquiries, not in the Netherlands, it's been considered that in the elderly, about 10% or more of women present prolapse and/or incontinence, and 1 out of 3 of them will have recurrent surgeries concern the problem and its eventual recurrences. Of course, all we know is the clinical presentation of this pathology with stage 1, stage 2, and stage 3 disease. And of course, all pelvic organs can be concerned isolatedly or in combination. One of the most frequent presentations is the cystocele, but uterus, when still present, is also submitted to gravity, to strains, and eventually to relaxing of supporting structure or to the absence of supporting structures when partial hysterectomy has been done, for example, and some upper ligaments have been retrieved. When the corpus uterine has been retrieved and the cervix is remaining, it can lead to enterocele also by relaxing of the structures. And finally, rectocele is also possible, or alone or in combination with the others, and mostly with cystocele, as we have seen in the first figure about grade 1 pathology. The common problem of all these pathologies is the presence of weak mechanical points in the base of the pelvis, with all the natural orifices which are supported with variable success by the surrounding structures. And if we look at it again from the clinical point of view, we can consider on this anatomical specimen that what really matters is the position of the central tendon of the perineum. But you see that the fixed structures, as the pubic arch or the coccyx, are quite far from there. And an essential structure to support this tendon are, of course, the different parts of the levator ani muscle, here seen from the bottom. The perineal body, the central tendon of the perineum, is made of a dense connective tissue. It serves as an attachment point to some perineal muscles to originate or to attach. And the perineal membrane, which is mostly anterior, because this is the rectum, but there is nothing here behind, and you will see on the whole figure that this posterior space is quite large. The perineal membrane is essentially anterior, and it's attached to the pubic arch and to the perineal body. Its role is to support the vagina and the urethra. In fact, for what regards the vagina, there are different levels of supporting. The upper level, which is at this level of cutting the structures, is represented here, and at this level, The upper vagina is supported by the uterosacral ligaments and by the cardinal complex. At the mid portion, which is an oblique point plane of cut, which is there and represented here as the transversal cut, there are still structures attaching the anterior part of the vagina to the arcus tendinus fascia pelvis and to the arcus tendinus rectovaginalis. And finally, the lower level, which is there, we find again the perineal membrane with some of the muscles which support it, and mostly here the superficial transverse muscle of the perineum and the pubo-rectalis muscles. With modern imaging, we can perform functional MRI studies in straight position, in vertical position, and then perform 3D reconstructions. We can make the structure turn and study the relationship between the organs and identify where are the weak points. And on the still picture, we can also evaluate in functional MRI what is the positioning of the organs with respect to some fixed anatomical point, like the tip of the coccyx here and the lower part of the symphysis there. And you see here a cystocele with an anterior presence of bladder below this anatomical line, which shouldn't be overpassed by the structure when the patient is straining or standing. Accordingly, you have understood already that the vagina is certainly the center of this pathology, not only because it's the place where it is clinically obvious and where the discomfort of the patient is the maximum, but also because of its central position near the mechanical point of the central tendon of perineum, and it's also a structure which can be accessible by a low approach or by an upper approach in order to lift again the structures into the pelvis. Some more complex and physiological studies have been also accomplished in MRI in order to identify the constraints. And when you apply some lecture of the mechanical strains, you see that the lines of highest density of these complex structure of the lower pelvis, the most solicited area corresponds, not surprisingly, to the presence of the ligaments. Many ligaments are present, and you have the uterosacral ligaments, which are posterior, coming from the anterior sacrum to surround the cervix, and we will see them importantly in the surgery, which will be illustrated later. We have the cardinal ligaments, which are more transverse and poorly represented here because their fixed point here is not represented. And finally, the pubocervical ligaments. But we have also pelvic muscles. The main, of course, is the levator ani with this important structure covering the whole lower pelvis. The pubo-rectalis muscle, which is here near the perineal membrane. The pubococcygeus muscles, which are more horizontal here. Long muscles at the surface of the levator. And finally, the iliococcygeus muscle, which is not represented. All these structures have been put in a kind of integral system theory, which is integrating the complex relationship between the components of the pelvic floor. The different muscle which join to assure correct opening and closure of all the natural orifices. The force vectors of these muscles can only act in the way they are supposed to, and to leaning to the periurethral and perivaginal connective tissues, which should be intact and in place, not removed, and not having lost their natural elasticity, which is a phenomenon which is observed in postmenopausal periods and, of course, with aging in general. The vagina coordinates these different forces and their vectors, and therefore the vagina itself, and we come again to the phenomenon of aging, the vagina needs to be elastic or not altered by the obstetrical history of the patient or the surgical history. So, prolapse in general and most pelvic floor symptoms mainly arise from laxity in the vagina or its supporting ligaments as a result of alteration of connective tissues, which can be measured as a reduction of presence of elastin or collagen fibers in the tissue. Again, an illustration of the perineal membrane, but I've been talking about this already so far. So where are we? We are with this central tendon of the perineum with distant structures, and the analogy with other mechanical problems is the analogy of supporting suspended bridges, where the true centrum, where the amplitude of vertical ligaments with the loading of the bridge is the maximum, but where the structures, the leaning points are extremely far from that point. So you have to lean with additional mechanical structures, and you can make analogies with the main cables and then the subdivision of the other cables, which are in fact dividing the constraints to absorb the main effort. And in modern bridges, we have an additional analogy because we have this center to be supported, and we have no true fixed point like a big tower here anteriorly, because the pubic bone is only here and cannot be really used. So that what is present in the back of the patient is the vertebral column with the sacral bone and with the anterior aspect of the upper sacral bone, which is, when the patient is standing, really vertical, as seen on the previous figures, which is really at the vertical point of the weak points that we need to support. This sacropolpopexy consists in placing meshes between these anatomical landmarks in order to fight the loosening of the tissues and the effect of gravity and strain. And this can be done with a posterior tape, with an anterior tape in intervesicovaginal, and you forget this one because this is not a true part of this integral theory. It's just a suburethral sling in case of strain incontinence. Of course, these meshes can be placed in the presence of uterus, in the absence of uterus, or with just remaining cervix with partial attachment still present. If we move now from this background to how the surgery is installed in these structures in order to achieve the goal, which is supporting the lower part of the perineum, you must realize that we have to act very anteriorly in the pelvis, and the first point of acting is aiming at this central tendon, which is on the midline between the vagina and the rectum, but which cannot be reached by itself. So we have to reach structures which are nearly and accessible, and with a line of force which is passing through the central tendon. So this is a true anatomical position on the right portion of the levator. This area is important. This one is just represented, but is not real. It's a projection here outside of this hemipelvis. And what we aim to do, of course, is to create this line of support at the level of the mid portion of the pelvis. Finally, as you see, when we are vertical, the best point which is accessible and can be used to create a mechanical link between this area and the vertical support is the promontory of the sacrum. Of course, this is not a structure where there is nothing important beside. We have the roots of the sacral nerves, the somatic nerves. We have also chains of autonomic system. And when this is covered, this by the tendinous structures and by the muscles, this becomes a little more complex, and finally explains that we don't have so many places where we can act without arming adjacent structures and still being mechanically effective. So that we have to find this point quite anterior on the levator, and avoiding to go lateral and posterior to the back of this area, which is quite wide and accessible to dissection if we want to extend this dissection. But where we are at risk to arm with a needle, for example, we can catch the content of the Alcock canal, which is here, and solve one problem, but induce another one, which would be much more discomfortable if we induce the deep pelvic pain just by catching the pudendal nerve. So this is this anterior mechanical point seen here on the tendinous structure instead of the muscular dissected pelvis. If we now move from a more surgical point of view, we have here the upper fixed point. This will be very detailed in the protocol, and we have there the projection of the points, the lower points, where we are aiming. We can reach there by an incision on the posterior peritoneum, starting from the promontory, which is here. Of course, this long incision in the deep pelvis has to be carried out on the right side, keeping in mind the course of the ureter, which is here more lateral. And we can't do the same approach on the left because of the attachments of the sigmoid loop. Now, just to mix the way we look at it, I have merged again the anatomical view of the deep pelvis with the surgical view, and we are aiming with this incision to find this point, which is, as we have seen on the lateral projection, which is anterior and lateral to the anal orifice. Very deep. We are literally on the inner aspect of the buttocks when we reach the adequate point. And taking the organs away, this is where we are aiming, but of course we have to reach this point without making such a disaster. We have to keep minimal. So we are trying to identify the inner fascia of the levator ani, anterior and lateral to the rectum or just below the posterior vagina. We'll see how we can materialize this posterior fold of the vagina during the protocol. And of course, the aim is to be able to place this structure. The posterior mesh is in a Y shape with these low points open and covering the lower rectum and this upper point at the promontory. This is the view we had with this dissection of the fascia, and when enlarged, you have the rectum here pushed away, retracted medially, and you see that the dissection has just opened the minimal window necessary to see the adequate portion of the levator, not developing the dissection too lateral or too posterior for the risks I have already mentioned. And you just place one stitch, moving away from the lower organ and catching adequately the deep fascia of the levator. You have a mirror image on the left. Here the rectum is retracted to the right, and again the fat of the ischiorectal fossa, which has been just open enough to make sure that you reach the fascia and not catching the wrong layer, which would not be stable mechanically. Then you have to make intracorporeal knots, and this is the way it ends, but this will be detailed several times later during this first part of the morning. And you have here this first mesh covering and merging these 2 points, and you understand that you have placed this transverse line of support passing at the level of the central tendon of the perineum. For what regards the anterior aspect, you have to develop a line of dissection between the low uterus, the isthmus, the cervix, and the posterior aspect of the bladder, going low enough to be at the level of the bladder neck, materialized by the catheter, in order to avoid, if you were steering too high, you would leave a lower part of the bladder at risk for sliding again and creating a recurrence of cystocele. You can materialize this anterior wall of the vagina with a surgical retractor, which is held by the assistant, and define your plane of dissection, keeping in view the bottom of the bladder materialized by the balloon of the catheter. And again, when you have dissected this plane, I don't go into details, you can place this anterior mesh, and finally, when both meshes have been fixed in their lower part, prepare the upper fixed point where they can be merged by a single knot in order to make this upper fixation and complete the procedure. So I think that I have finished to browse this anatomical context of this surgery.